Hello, my name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for the MAVEN Project. And thank you all for joining us today. And thanks to our friends at the Community Health Center of Franklin County in Massachusetts for requesting today's session, Pre-operative Cardiovascular Evaluation with Dr. Robert Lohr. Dr. Lohr was born and raised in Columbus, Nebraska. He received his BA and MD degrees from Northwestern University in Chicago and completed his residency in internal medicine at Hennepin County Medical Center in Minneapolis, Minnesota. He practiced general internal medicine at the Mayo Clinic in Minnesota since 1993, in recent years primarily perioperative medicine. He staffed the Mayo Pre-operative Evaluation Clinic and the Internal Medicine Consult Service, which focused on perioperative medicine. Dr. Lohr was a speaker for several years at the Mayo Perioperative Medicine Update. Welcome today, Dr. Lohr. Thank you so much, and I'll turn it over to you.
All right, thank you very much, Jill, and good afternoon, everyone, and good morning to those of you who are in the West. I know you all see pre-op exam patients on a regular basis, so this, I hope, will be a topic that you'll find useful, and I hope by the end of the hour, you have some practical tips and sort of a good structure to do an evidence-based and complete pre-op evaluation. I don't have any disclosures, and Jill talked to you about obtaining credit. Our objectives for today are to evaluate the basic elements of a complete pre-op evaluation, although we're going to focus on the cardiac aspects, to determine when to order testing, when you don't need to, and also what testing to order, to apply evidence-based cardiac risk evaluation tools, and to incorporate the current ACC, AHA, that's American College of Cardiology, American Heart Association guidelines for a cardiac evaluation before non-cardiac surgery. Now, these guidelines were very recently updated. The old version, but previously current version, was 10 years old, 2014, and the new version came out about 6 weeks ago. So we're going to highlight, or I will try to highlight, what changes there are. A lot has stayed the same, but there are some significant changes, particularly the use of biomarkers and also the type of some testing that is recommended. I won't go over this because Jill just did by way of introduction, but I will emphasize that I'm not a cardiologist, even though we're doing this cardiac evaluation. So I'm going to be presenting this from the standpoint of a generalist, which I hope will fit well with what you all are doing every day. So first of all, why are we doing pre-op exams? I know that when you are requested to see a patient, the request almost always says, please clear Mr. Jones for whatever's coming up. But you're really not giving clearance, and I would recommend not using that word in your note. You are doing a consultation. You're performing an evaluation of the patient's current medical status, particularly as it's germane to their operation, and you're going to be making recommendations concerning any further evaluation, management of risk factors, cardiac and otherwise, and any other problems over the entire perioperative period. And the audience, of course, is the patient, but also the surgeon and the anesthesia team. Now, this was consistent with the old guidelines and is consistent with the new guidelines as well. It's better at the end of your note, rather than to say, Mr. Jones is clear for his whatever, to say, I've evaluated Mr. Jones' medical status and they should be able to proceed with the planned procedure with the following recommendations, and then you can list them 1, 2, 3. If you say they're cleared and something does go wrong, which it can, even in the best of circumstances, you are somewhat liable. So I would avoid using the word. I know that the surgeons and the people referring these patients to you use it, but I would not use it in your responses. Now, every patient who you see, you need to address these areas. We're going to spend most of our time today on the heart. Pulmonary complications are actually the most common type of post-op and perioperative complications. This evaluation, I should say, pertains mainly to people with COPD and asthma or other chronic lung conditions, but those are the most common ones. Many patients are diabetic, and so you do need to be giving some instruction to the patients about what they should be doing, at least up to the day of surgery and including the day of surgery with whatever treatment they're on. And we'll talk about that at the end in terms of medication management. Many patients are now anticoagulated. And the question is, do they need to have the anticoagulation stopped or not? It doesn't always have to be. And if so, when? And when do you restart it? Do they need bridging, which is not commonly done anymore, but for very high-risk patients, it sometimes is. And so those questions have to be addressed as well. The patient's medications need to be reviewed in pretty careful detail, including over-the-counter medications. There are medicines that you want them to take the morning of surgery, and there are medicines that you don't want them to take. So you have to be fairly explicit about that. And then other refers to other conditions that, if they are decompensated, can have adverse perioperative effects in terms of morbidity and mortality. So decompensated cirrhosis, renal failure, and thyroid disease. Thyroid, mainly hyperthyroid, not hypothyroid. And those are all sort of separate talks, but those are areas that do need to be addressed. Every patient, you should ask about their anesthetic history, if they've had surgery before, if they know what type of anesthetic it was, if they had problems, even if it's something as common as nausea when I woke up. If you note that, the anesthesiologist can actually mitigate that to a large degree right after the surgery. Bleeding and clotting history, including their family history. Their alcohol use, and the question you should be asking is how much and how often. I drink socially is not an adequate response. You need to know how much and how often. Alcohol withdrawal post-op is very dangerous, difficult to manage, and sometimes fatal. Their tobacco use. This particularly is important if they have severe COPD or asthma and are continuing to smoke. Smoking cessation, even up to a few days to a week pre-op, will help mitigate their pulmonary complications. Steroid use, because if they're on a significant dose, they will need to have some augmentation of their steroids pre-op. Other drug use, including anything and everything that they might be able to obtain on the street, including marijuana. Marijuana is a sympathomimetic, and it actually can increase cardiovascular risk in the operative setting. Chronic pain medicines, particularly buprenorphine, if they're on high dose, that may need to be adjusted down. Everyone should be screened for OSA if they don't have that diagnosis coming in. And finally, frailty, which is a new recommendation from the ACC and AHA this year. Okay, let's start with a case. And we're going to spend most of the rest of the time, I hope, explaining how to respond to this case. And I think this is a typical patient for you. 76-year-old male is scheduled for an elective total knee arthroplasty, TKA. He has a history of coronary artery disease treated medically, so no stents, no bypass. He is not able to perform 4 METs. Now, we're going to talk in detail about what that involves, but I'll tell you at this point that that is the level of exercise that if patients can do 4 METs, even with cardiac histories, they should be able to proceed really without too much, if any, further evaluation. Now, he is limited in his activity mainly by his knee, and he does say that he can do water aerobics without symptoms. So I think we have an idea that he's in pretty good stead, but we're not terribly confident about his functional capacity. He takes metoprolol, aspirin, atorvastatin, and lisinopril, all at quite reasonable doses. The exam is really pretty good, noteworthy for normal vital signs. Blood pressure could be perhaps a little lower, but it's pretty good. No neck vein distension. His lungs are clear, and he has a mid-systolic murmur at the lower left sternal border without radiation. So nothing that sounds terribly worrisome. So you advise the following. Your first choice is a BNP and a troponin. The second is a dobutamine stress echo with cardiology consultation to follow. The third is a cardiogram, electrolytes, a BNP, troponin, and continuing his medicines, although you'll note that lisinopril is not on the list of medicines to continue the day of surgery. Number 4 is a coronary angiogram, just send him right to the cath lab. And number 5 is a cardiogram, electrolytes, continue the medicines, and also do a DSE, dobutamine stress echo, pre-op to facilitate additional recommendations. Now, we don't have audience participation, so I can't ask you to raise your hand, and I'm not going to give you much time to think about this because we have a lot to cover. So I think that the best answer is number 3, cardiogram, electrolytes, the BNP and troponin, which are, again, new recommendations. That's why the asterisk is there, and continuing his medications. And as I said, what we're going to do in the rest of our time is to explain why this is the best answer and why the others are not the best answer. And we'll come back to this at the very end of the presentation. So step number 1, when you're evaluating the patient, is this an emergency? Now, in your clinic setting, that's not going to come up very often. It potentially could. But usually this is more in the setting of an emergency room, but it can happen in the office. People come in with symptoms that they don't understand, and it turns out that it's really sort of a crisis. If it's an emergency, you're done. You don't do any further evaluation. You get them to the operating room. If it is not an emergency, then you need to do some further evaluation. I have at the bottom of this slide the complete reference for the new guideline, by the way. So that will get you to that guideline should you wish it. It's quite lengthy and detailed, but it's very interesting reading. So what's an emergency? This would be life or limb threatened if the patient is not in the operating room in under 2 hours. So this would be something like a ruptured abdominal aortic aneurysm. A dissecting aneurysm, something where they're going to bleed out. Perhaps someone who has a ruptured abdominal viscus and they are already septic. Those people need to go to the OR and they need to get there quickly, and you're not going to slow things down by doing an extensive evaluation. An urgent operation would be life or limb threatened if the patient's not in the OR between 6 and 24 hours. And I think the best example of this is a hip fracture. And you're saying, what's the rush on a hip fracture? Well, most people who break their hip are elderly, often over 80. And there's a lot of evidence that delaying the repair of the hip really increases morbidity and mortality. So if the repair is extended well beyond 24 hours, so a couple days, there's a much higher incidence of DVT, PE, MIs, aspiration, delirium, none of the things that you want to have happen. So there is some urgency in doing a hip repair. Time sensitive would be 3 months. You want to get things done, but not immediately. You don't have to rush the patient to the OR. So this might be a new diagnosis of say, colon cancer. It's not obstructing. They do need surgery, but you don't have to do it this minute. Elective is indeed that. You can delay it forever if you want. I also want to define risk in terms of this discussion. We talk about risk of major adverse cardiac events, which is abbreviated as MACE. And for the definition of high and low risk, which is widely accepted, low risk is anything under 1%. And 1% or greater is considered elevated risk. So it's a fairly high bar. Okay, we don't have an emergency. The next question you need to ask yourself is, are there active cardiac conditions? And I call these the showstoppers, because these are all conditions that warrant an immediate conversation with the surgeon saying your patient can't go to the operating room as planned. We have to evaluate this problem. And the surgeon will say, well, I might have an opening next week. Can we do it then? And your answer should be, we'll call you when we're done, because you don't want to be under the gun either. Now, these are quite obvious. If someone comes in and they're having unstable angina and you're doing a pre-op exam, that clearly needs to be investigated. new angina or angina with a low level of exercise. Also, an MI within 30 days, and we're going to talk a little bit about that 30 days because that's a little bit of a gray area. I would say it's a significant gray area right now. Decompensated heart failure or new onset heart failure would be a showstopper. Significant arrhythmias. Now, many of these are ventricular, which should be pretty obvious that should be dealt with. The most common thing you're going to encounter in an office setting or a clinic setting, however, is a supraventricular tachycardia where the resting rate is over 100, and anesthesia would like that to be less than 100 to start with. And then lastly, severe valvular disease. Most commonly, the lesion that will stop an operation is aortic stenosis, which is quite common. The echocardiographic criteria for severity is a gradient of over 40 millimeters across the valve and a valve area of less than 1 centimeter or symptoms. Now, mitral stenosis with symptoms also would be a showstopper. We see very, very little mitral stenosis in the United States, or in the developed world, I should say. And the reason is that it's caused by rheumatic fever, which is caused by untreated streptococcal infections. And we treat all of our streptococcal infections and sore throats and the like. So it's vanishingly rare here. But if you go to a developing country, it is not. I had the opportunity to spend some time in Haiti a few years back, and it was very common to see mitral stenosis and often with associated heart failure. Now, I want to go back to the time that you need to think about delaying if there has been an acute coronary event or a CVA. This was a British study published about a year ago, longitudinal retrospective, and they looked at outcomes, which was the primary outcome was mortality at 30 days post-op, and the secondary 60, 90, and 365 days post-op. A huge study. They have the National Health Service, so they can enroll everybody that lives in England, or in the UK, I should say. So with patients who had a previous event, the post-op mortality was increased until there was a plateau at almost a year, 11.3 months for the primary endpoint and 14.2 months for the secondary endpoint. So if this is truly an elective operation, and I would consider at least having a serious conversation with the patient and the surgeon about delaying this procedure longer than just 30 days. They are at high risk for having problems. And I don't have a slide on this, but there was an article just published in JAMA Surgery, October 30th of this year. And they looked at patients who had had an NSTEMI, so a non-ST elevation MI, and they looked at those patients who had major adverse cardiovascular or cerebrovascular events after non-cardiac surgery. And interestingly, the patients who were not revascularized had high risk going out 2 to 3-fold higher. Those that were revascularized seemed to plateau between 90 and 180 days. And so they suggested that if there's been revascularization, you might go 90 to 3 months to 6 months. Interestingly, after 6 months, the risk seemed to go up, and that wasn't clear why that would happen. So this is a little gray. I think in general, when you're faced with a question like this, it's better to err on the side of being conservative rather than subjecting the patient to some risk that they don't have to be subjected to. So, no emergency, no active cardiac conditions. Are there other cardiac risk factors, and are they modifiable? Now, the new guidelines define cardiac risk factors as severe valvular heart disease, which we've talked about, pardon me, severe pulmonary hypertension, elevated risk congenital heart disease. Now, those patients you're probably not going to see in a primary care setting because they're going to be managed by cardiologists in general. You could. So someone has very significant pulmonary stenosis, we'll say. But I think if you encounter that, I would get them to a cardiologist. Prior coronary stents or bypass, recent stroke or TIA, and we just talked about that. Recent is a bit of a moving target. an implantable defibrillator, pardon me, defibrillator, and frailty. So if any of these are present, you need to utilize a validated risk calculator, and we're going to go in some detail reviewing the three most commonly used calculators right now. And if there is higher risk, you'll need to do assess their functional capacity, and we're going to talk about how to do that as well. I want to go back to valvular heart disease just to show you an example, because it is a modifiable risk factor. So if someone has clinically suspected moderate or greater degrees of valvular stenosis or regurgitation, or a change in their clinical status, you obviously need to get an echocardiogram to verify what your physical exam has suggested. And if the patient meets the standard indications for valve replacement or repair, that actually should be done prior to the elective surgery that you're seeing the patient for, especially if their EF is under 50%. So if you're seeing the patient for a total knee, as our patient has, and you hear a murmur that you think is severe aortic stenosis, you should get an echo. And if it really is severe, and particularly if they're having symptoms, that needs to be addressed before the knee. The question you might ask yourself, and I'm going to ask you right now, are what are the physical findings of severe aortic stenosis? Because you may not have an echo previously done, and so this may be a new finding. It is not the intensity of the murmur. There are two factors. One is the late peaking of the murmur. It should be crescendo, decrescendo. In severe aortic stenosis, it crescendos late, almost up to S2, and then falls off. So it's a late peaking murmur. And the other is what we call parvus and tardus of the carotid upstroke. And you assess that by listening with your stethoscope at the second right intercostal space, which is where the AS murmur should be loudest, and simultaneously checking the carotid pulse. Now, normally you hear S1 and you feel the carotid upstroke. It's almost simultaneous in terms of what we can feel. In severe aortic stenosis, it is delayed, which is tardus. In other words, it isn't right there right away, and then it's moderated. It's not a nice upstroke and down. It's more of a curve. So it's that is called parvus. So it's tardus and parvus of the carotid and the late peaking murmur. If you have those characteristics, that patient probably should get an echocardiogram. Now, in reference to the last bullet on this slide, there are times when you can't repair the valve before the surgery, and the surgery must be done. So let's go back to our hip fracture patient. That's an elderly person, comes in with a hip fracture. They've got severe aortic stenosis with or without symptoms. Well, you can't get that fixed within 24 hours. So the patient needs to go to the OR, and your job then is mainly that of a communicator to the surgeon and to the anesthesia team about the status. Typically at our institution, my institution, if we identify that sort of a patient, they will change the anesthesia team from the group that usually deals with orthopedic patients to one that deals with cardiovascular patients, so that they have more experience and more expertise in dealing with this type of thing. And then they should be monitored in the ICU post-op. Okay, now this is an important slide because this actually encompasses a lot of algorithmic options for you, and we will have an algorithm at the very end. So we have no emergency, no active cardiac conditions. You've done a risk assessment. MACE is less than 1%. Surgery may or may not be low risk, but you can proceed to the OR. You don't need to do anything further. Surgery is not low risk, or the patient has risk factors. Get their functional capacity. And if their functional capacity is poor, get a troponin and a BNP. If the functional capacity is good, you can proceed to the OR without the BNP and troponin. And then if the BNP and troponin are abnormal, then you need to consider further testing. And the one new recommendation this year is the coronary CTA and or some stress testing and perhaps a consultation. Now we're going to come back to all these steps in a second, but we're going to now proceed to risk assessment and then functional capacity. First of all, low-risk procedures. These are things that you probably don't see patients for pre-op evaluations, with the exceptions of a couple. Certainly endoscopic, dermatologic, no. Cataracts, yeah, I know you do see them. Breast surgery, ambulatory surgery, dental procedures. Breast surgery is low risk unless it's a radical mastectomy, which is very rarely done anymore. Cataract surgery is extremely low risk. It is a 20-minute procedure with local anesthetic. And frankly, we do not do pre-ops on cataract surgery patients. We ask our anesthesia colleagues to do their screening that they normally do. If there are some red flags, then we may end up seeing the patient, but basically they don't need a pre-op exam. And I know you get asked to do that. So this is an opportunity to talk to your ophthalmology colleagues. Most of the patients you see that do need some pre-op evaluation are in the intermediate risk from a surgical standpoint category. Intraperitoneal, intrathoracic, carotid endarterectomy, head and neck, orthopedic, prostate, and urologic procedures. High risk, you may not see that much of. These are aortic and major vascular, as well as peripheral vascular procedures, pulmonary and liver transplantation, and pneumonectomy. Those patients are often, almost always, followed by specialists, and the pre-op evaluation would be done by them. But those are high-risk procedures nevertheless. I want to tell you that the Canadian Cardiology Society guidelines are different than ours. These were published in 2017, so fairly recently. They do not recommend, under really any circumstances, any type of stress testing. They do recommend for patients over 65 or between 45 and 64 with a history of CAD, stroke, peripheral arterial disease, PAD, heart failure, or severe pulmonary hypertension, or they have an RCRI score, which is a risk calculator, which we're going to talk about, which is greater than or equal to 1, that the patient should have a BNP. And if the BNP is elevated, then they should have post-op monitoring and troponins, as well as co-management with a medical specialist. No stress testing, simply get the BNP, and if they're high risk, monitor post-op and go from there. Now, the reason that they do this is that the stress testing often leads to revascularization, and it's not clear that that really helps. The 2024 American guidelines will suggest a BNP and or troponin in the same age group with known CVD or symptoms of CVD, but not right out of the gate. It's usually depends on the patient's risk, as we'll see. Okay, risk calculators. The oldest one, and the one that you may use, it's very simple and been around for a long, long time, is the RCRI, the Revised Cardiac Risk Index. And as far as the RCRI is concerned, these are the risks that will give you points specifically. They'll get you a point for a high-risk procedure, and they include intraperitoneal and intrathoracic, as well as major vascular procedures, history of CAD, heart failure, stroke or TIA, diabetes treated with insulin. Now, realize that these were developed in 1999, well before all the new drugs that we have to treat diabetes. So it still is with insulin, but that is a little bit suspect. And then a preoperative creatinine of over 2, which implies a GFR of less than 30. So any of those will get you a point. And here's how the points come out in terms of risk. So no points is 0.4%, and 1 point is 0.9%. Anything over that, so 2 or 3 plus points, is high risk. But as I said, we didn't have troponins, and we didn't have BNPs, and we didn't have some of the diabetic management tools that we now have. So questions have been raised about how sensitive the RCRI is. There was a Cochrane database systematic review a couple of years ago, and it indicated that the RCRI would be improved when the if there was a BNP or troponin done, or a combination of those done. There was also a retrospective study in the Canadian Journal of Cardiology in 2021, big study. They found 35% of patients had major adverse cardiac events, including MINS. This is another thing for you to remember, myocardial injury with non-cardiac surgery. These folks had an RCRI score of 0. So the RCRI did not pick everybody up, and they would have been detected. They would not have been detected without a high sensitivity troponin evaluation. So if you're using the RCRI, and you can certainly use it, but if you come out with a score of 0 or 1, I would do an additional risk calculator, either the next one we're going to talk about, which is called the NSQIP, or the AUB has 2. Okay, let's talk about the NSQIP, National Surgery Quality Improvement Program. This is from the American College of Surgeons, and it just had a new version released in June of 2023. And I'm actually going to walk you through this, and we'll create a case and demonstrate how you fill it out and the information that you get, because you get a lot of information. You do have to put a fair amount in, but you get a lot of information. So we're going to go to the ACS site. I am not a robot, and they're going to make me look at pictures here. So stairs and stairs. Anybody see any other stairs? I don't think so. Okay, and I have read their thing. Okay, now the first thing you have to put in here is the procedure. And so we're making up a case. So this patient is going to get a thoracotomy for a lung nodule. So all the codes for thoracotomies come up, and we're going to say a thoracotomy, therapeutic wedge resection for a mass. Okay, and you also have to say, are there other appropriate treatments? And in order to go on, you have to say no. Our patient, we're going to say, is 80. So elderly. She is female. Obviously, she's female. She is partially dependent. It is not an emergency. They do ask you to fill out the ASA class. This is the American Society of Anesthesiology classification that has been around for 70 years. It's very well validated. The anesthesiologists use it to this day, and it helps them manage their patients in terms of risk intraoperatively. But it's pretty simple to do. So class 1 is a healthy patient. Class 2 is mild systemic disease. So this might be asthma, well controlled, hypertension, well controlled. Severe systemic disease would be maybe any of those, hypertension, diabetes, not well controlled. Severe systemic disease, constant threat to life. So someone with active angina, someone with bad COPD. And then moribund, not expected to survive. This would be an emergent surgery, somebody who's really looking bad to start with. There is a class 6, which is used for organ donation. And we're going to say that our patient has severe systemic disease. We're also going to say that she's going to have COPD and that she has used steroids recently. She does not have ascites. She is not septic. She is not on a ventilator, and she does not, as far as we know, have disseminated cancer. We will make her diabetic on insulin. We'll say that she is hypertensive. We'll say that she has some dyspnea with exertion. She has not smoked within the year. She does have severe COPD. She's not an acute renal failure. And we're going to make this lady on the heavy side. Okay. So we filled in the baseline stuff here. Now, she's elderly. This is new. They have a couple of geriatric questions which get to frailty, which is important. So we are going to fill these in. We'll say she does use a mobility aid. She came from home, and she does have a fall history, and she's a little confused some of the time. She is not in hospice, and her daughter did do the paperwork. Okay. I'm still not a robot. Okay, so this is what you get. Any serious complication, any complication, pneumonia, cardiac, surgical site infection, UTI, VTE, renal failure, readmission, return to the OR, death, discharge to a nursing home, sepsis, and then to the geriatric things, post-op delirium, functional status decline, need for a new mobility aid, and worsening pressure ulcer. This is the risk of the patient, and this is the average risk. So we're talking about heart problems today. Her cardiac risk is 2.7%, and normal would be under 1%. But you can see you have a wealth of information to provide the surgeon, the patient, the family. I think one of the most important ones when you're counseling a family is the delirium risk. And when you have an elderly patient like this, to talk to the family how likely it is that there may well be some confusion post-operatively, particularly if opioids are needed, and they almost always are, for pain control, at least for the first few days. I think the surgeons are getting much better at tapering the opioids quickly, but nevertheless, the first few days there is going to be some. So this presents a good picture of what the patient has, and how you might be able to manage some of it. Okay. The last calculator we're going to talk about is called the AUB has two, and AUB stands for American University of Beirut in Lebanon. This is also very simple, similar to the RCRI, but it does have better sensitivity. The HAS is H for heart disease, A for age or anemia, and S for surgery. So the H has two, and they all have two components, and each component gives you 1 point. So a history of heart disease or symptoms, age over 75 or over, and a hemoglobin of less than 12, emergency or vascular surgery. So this is how the points come out. If the score is 0, you're under 1%. Anything over that, it gets into a higher risk situation. So again, this is quite simple to use. You don't get nearly as much information as you do from the American College of Surgery calculator. But from a cardiac standpoint, MI, CVA, death within 30 days, you get a pretty quick answer. So it's easy to use. Okay. So the patient's high risk, we now want to assess their functional capacity. We want them to do 4 METs, which is to be able to climb a flight of stairs or walk up a hill 1 or 2 blocks. 10 METs is strenuous exercise. If they can do 4 METs, they should be able to proceed to the OR. Now, if they cannot do 4 METs and they're high risk, then you do need to think about some further testing or a coronary CTA. So how do you assess the functional capacity? You can ask them questions, but that has been shown to be less accurate than a more structured approach. Now, this tool has been around, again, for a long time, 1989, but it is endorsed up to this year in the current guidelines. It's quite simple to use. It's the Duke Activity Status Index, DASI, and a score of over 35 suggests a decreased risk of MI or death. These are the questions, and I'm not going to read through these with you. You can do that at your leisure. But I will say that you can have this embedded in your electronic record. You can have it printed out, have your nursing assistant or your nurse go through this with the patient before you see them, because very often you want to know their functional capacity. And then you've got the information when you need it. So we have a patient now who has a high risk, who has a poor functional capacity, or we can't determine it. And because of the poor functional capacity, we got a BNP and it's elevated. So what do we do next? The best way to approach this, I think, is to take the surgical question out of the equation. So rather than thinking I'm seeing this patient preoperatively, saying I'm just seeing this patient for a general exam in the clinic. Based on the information that I have, would I do further evaluation, which would be, again, some sort of a stress test and or a coronary angiogram, a coronary CT angiogram. If the question is, yes, I would investigate this patient, then I would go ahead and do it, particularly if the patient, the surgeon, and the anesthesiologist all agree that this would impact, how they would manage the patient postoperatively. Having said that, doing routine revascularization has never been shown to be helpful. So you need to have a pretty good reason to do it, but someone who meets all these criteria probably does. I want to spend a few minutes on some other interventions. Beta blockers is the first one. Beta blockers have been around, of course, for decades and decades. And a while back in 2008, there was a study that suggested that giving beta blockers, specifically atenolol, was really helpful and decreased cardiac risk. And then the study was discredited. There was some fraud. So then people didn't know what to do. The POISE trial was then done in 2015, and that suggested that there was harm if you gave beta blockers. However, the protocol for the POISE trial was that you gave beta blocker naive patients 200 milligrams of metoprolol pre-op, and then another 200 milligrams 6 hours post-op. Well, that's a huge dose. And not surprisingly, they had a lot of hypotension and they had a lot of MIs and they had a lot of strokes. And so they said, well, it's harmful to give. I think at that dose it is, but it didn't really prove that it's harmful to give. There have been some other studies that suggested that that beta blockers may increase MACE, particularly if they're started immediately before surgery. So if someone is on a beta blocker, you should continue it. For whatever the reason they're on it. If they are not on it and they have, and this is an older reference because it refers to the RCRI, but if they have 3 or more RCRI scores, consider starting one before surgery. If there is some long-term indication for a beta blocker and they're not on it, but there's no cardiac, major cardiac risk things, you should not start it. If you choose to start a beta blocker, you need to do it about a week before the surgery. And you need to see the patient back to assess their blood pressure, their pulse, their breathing status, make sure that they're tolerating the dosage well. You should not start the day of surgery. That's the key. And I think there is some harm associated with it. I know there is. Hypertension, it's a pretty low bar. If they're under 180 over 110, they can go to the OR. Anesthesia, really is happier with high blood pressure than low. Antihypertensives generally are given the day of surgery, with the exception of diuretics. And you need to think about if they are on an ACE or an ARB, because those drugs can result in a pretty significant systolic drop in blood pressure with induction of anesthesia for up to 30 millimeters. There is some new data on ACEs and ARBs. This was a fairly recent, well, this was in August of 2024, a randomized trial, which looked continuing the ACEs or ACE and ARB until the day of surgery, or the other side of the other arm was to stop at 48 hours pre-op. And the outcomes were the same. 22% of each group had some with a primary outcome, but nobody took the drug the day of surgery. So it still doesn't answer what you should tell the patient the day of surgery. Now, what I tell patients is I want to know what your blood pressure is normally at home, and I want to know what it is in the clinic when I'm seeing them. If they are really well controlled, 110, 120 systolic, I would hold the ACE or ARB the morning of surgery. If they are poorly controlled, you probably can give it. Okay. Statins should be continued. You can consider starting them. It's quite safe to do. In vascular surgery, if they're not on a statin, you probably should start one. Alpha-2 agonists have no role. You don't have to worry about those at all. Antiplatelet drugs. And I'll tell you, I will go through this, but you're going to have to either memorize it or look it up every time, because they've made the indications and the guidelines kind of complicated. And you'll see that. So if you have a patient with a drug-eluting stent for an acute coronary syndrome, and the surgeon says you have to stop both antiplatelet drugs, you need to delay for a year. If it's a drug-eluting stent for chronic coronary disease, and the surgeon says you have to stop both drugs, you need to delay 6 months. If it's really time sensitive, 3 months if it has to be done. Now, there aren't too many surgeons that'll say you have to stop both aspirin and the clopidogrel or ticagrelor or whatever else they're on. But neurosurgeons, particularly with craniotomies and spine surgery, will do that. If there's just a history of a prior PCI, continue aspirin. If within 30 days of a bare metal stent or 3 months of a drug-eluting stent, you should continue both drugs, both antiplatelet drugs. If the patient's on an oral anticoagulant, the new guideline says replace it with aspirin perioperatively. If there's no PCI, but they're on an aspirin for a reason, then continue it. And I have never done this, and I've frankly never seen it done, but you can bridge with IV therapy antiplatelet drugs. So again, the fact that you have to determine whether it's ACS or chronic disease and so forth is you're going to need to refer to something when this question comes up. Troponin and ECG symptom, if ECG symptoms, I'm sorry, troponin and ECG if symptoms of an MI, or if the patient has positive biomarkers, but routine post-op screening is not really indicated unless they came in with positive biomarkers. And again, the Canadian guidelines are somewhat different, as we talked about. Now, what about patients with COVID? Because you're going to encounter those and probably have. And I know this is not the easiest slide to read, so I'm going to walk you through it. On the left side, we have the time from COVID-19 diagnosis, and on the right, the risk of major adverse cardiac events, and it's either low or elevated. So patients with mild COVID, asymptomatic, mild, moderate illness, and it's been less than 7 weeks, no matter what their cardiac risk, you should delay surgery. If it's over 7 weeks and they are low cardiac risk, you can proceed. If they're high, you may be able to proceed, but it may be better to delay things a little longer. Now, if they had severe COVID, and it's less than 7 weeks, you would delay no matter what the risk is. If it's over 7 weeks and they're still symptomatic, you would delay no matter what the risk is. And if it's over 7 weeks with resolution of symptoms, and it's low risk, proceed, high risk, maybe proceed, but be cautious about it. This is a study from about a little over a year ago, based on the timing of surgery post-COVID. This is also from the UK. So even though only 3% of procedures were conducted less than 7 weeks after COVID, they still had a lot of patients. And they found that after the availability of vaccines after they were widely available, the mortality was 1.1% of surgery within 2 weeks of the COVID diagnosis and 0.3% if within 4 weeks. So this suggests at least that in asymptomatic patients, if the surgery is urgent, a new cancer diagnosis, for example, that it may be safe to perform in under 7 weeks. Okay, everybody should be screened for OSA. If they have OSA, they should bring their CPAP or whatever treatment with them to the hospital. If they don't, and you screen them, then you need to make sure that that's clearly noted in your note. And you're familiar with the tools. Unrecognized, untreated OSA perioperatively does increase morbidity and mortality. Patients should be monitored with continuous oximetry. Consider the ICU post-op, and if it's an outpatient procedure, consider moving it to an inpatient setting if they have not been diagnosed and they seem to have it on the basis of your screening. Okay, these are new recommendations from the new guideline. Stable patients with pulmonary hypertension, stable regimen of meds, simply continue their meds. For severe pulmonary hypertension, or if they are unstable, you need to engage cardiology. They basically need to be seen. And then I think importantly, because this happens a lot, for a new fib in the perioperative setting. So you get the patient back 3 weeks after the surgery, and there's a little note that they had 12 hours or 24 hours or whatever of atrial fibrillation, and then they converted to sinus rhythm. Historically, we said, well, it was the surgery or their magnesium was low or whatever, and we don't do much about it. But the evidence now suggests that these patients are at risk for recurrent AFib and subsequent problems. So you need to evaluate them as you would any other patient with new atrial fibrillation. Consider anticoagulation and further evaluation. Medications. For blood pressure, we generally hold diuretics. Patients are NPO, and then they're getting a lot of IV fluid, a lot of fluid shifts, so we don't give a diuretic the day of surgery. And then we've talked about holding the ACEs and ARBs. I should mention too that there was another study that recently came out looking at the ACEs and ARBs for holding it or not, and it really was unclear whether it was a good idea to do or not. I think it's better to err on the side of being conservative. For diabetics, PO meds generally should be held. Now, the main one here is metformin. If they are on a sulfonylurea orally, that should certainly be held. If they are on an ultra long-acting insulin, Lantus, for example, that can generally be given at full dose. Now, the caveat here is most of the time people take that in the evening. And I always ask them, what's your blood pressure first thing in the morning? Not blood pressure, blood sugar first thing in the morning. And if they say, well, it's 90, I would probably cut back on the Lantus dose, maybe by 25 or 30%. If it's 110, 120, 30, go ahead and give the full dose. Intermediate acting insulin, NPH, should be decreased by 50% the day of surgery. SGLT2 inhibitors should be held for 3 to 4 days pre-op. So these are the sodium glucose transport inhibitors. Many people are on these drugs. The reason for this recommendation is that, as you should know, these drugs can cause a normoglycemic ketoacidosis. Now, our patients perioperatively they're NPO, they're getting IVs, they're not eating, and the risk of that goes up. So we want these drugs out of their system completely. So that's why you should stop 3 or 4 days ahead of time. The GLP-1 receptor agonists, the glucagon receptor agonists, the anesthesiologists recommend holding the day of surgery if it's an oral dose, or the week of surgery if it's injected weekly. Now, the background for this, or the rationale, is that these drugs do delay gastric emptying, and that's how people lose weight. And therefore, if they have retained gastric contents, they're at higher risk for aspiration. Now, there's been several studies that say you don't need to hold, or you can fudge it a little bit. There was a study suggesting that in emergency surgery, you didn't need, you couldn't hold it. The patient, it's an emergency, you had to take them to the operating room. And there really was not an increased risk of aspiration. However, in an emergency setting, the anesthesiologists do rapid induction and they mitigate the risk of aspiration. So I'm not sure that study tells us what to do. There was also a very recently released study, it just came out a week or so ago, from a journal it's about obesity. And they had two recommendations. The first was that if you were escalating the dose of the GLP-1, or if they're on a high dose or weekly dosing, which apparently causes more problems, or if they have symptoms, or if they have some other condition that would delay gastric emptying, then you should hold the drug. If you're going to give the drug, they have several mitigating things that you can do, and they involve point of care ultrasound to look for gastric contents, rapid induction by the anesthesiologist, that sort of thing. So it doesn't, from the standpoint of you doing a pre-op exam, it doesn't really help you too much. I think it's important to, make sure that anesthesia knows they're on this drug. And I don't think there's great harm in holding it for a week or so. We've talked about beta blockers and other cardiac drugs. Anticonvulsants should be given. Pain meds generally or always should be continued. If they're on a high dose of buprenorphine, you may need to taper that down to 16 or 18 milligrams in order for their pain to be otherwise controlled post-op. Give the Parkinson meds, MAO inhibitors, and inhalers can all be continued. Screen for frailty. And again, the American College of Surgeons tool will help you do this. There are other tools, but it's important to do because it does have an impact. Now let's wrap up by going back to our case. So we have a 76-year-old man with a history of heart disease, so with some risk factors, and we're not sure, we've done the risk stratification. We really don't know his functional capacity, and we're not really able to determine it because of his knee. So we did a BNP, and we do want to do a BNP and a troponin. We want to continue his medicines, maybe holding the lisinopril the morning of surgery. He needs a baseline ECG, and baseline can be up to a year old if he's been clinically stable. He needs electrolytes because he's been on lisinopril. If the BNP and troponin are positive, you need to think about some additional questions, additional studies, but you don't have to. So this is inadequate. You don't have to go right to a stress test. You certainly don't have to go to angiography. And again, you don't jump to a stress test. And this is the sequence. So we're going to review the entire thing. Emergency, yes. To the OR, no. Active cardiac conditions, yes. Then you need to address them. No. Estimate risk using a calculator. Low risk, go to the OR. Increase risk, if you can modify, fine. Assess their functional status. Functional status good, go to the OR. If it is poor or you can't determine it, get a BNP troponin. If they are normal, go to the OR. If they are abnormal, consider further stress testing, coronary CTA, delay surgery, or a consultation. Thank you. I talked more than I should have. I think we have a few minutes for questions, and I'm happy to stay on longer if there are other questions. But it's been a pleasure to spend some time with you this afternoon. So, questions?
Great. Dr. Lohr, thank you so much for that great talk. I'll have you stop sharing your screen, and I don't see any questions right now. I'll just do a little bit of talking, and if people have questions, they can put them either in the chat. Oh, here we go. Here's one. Can you remind me of the language you recommend for to use instead of
Instead
clear?
of clearance?
Yeah.
Yeah, I'd say Mr. Jones should be stable to proceed for the planned procedure, whatever it is, with the following recommendations. Get a cardiogram, do the, hold is this, give that, and so forth. So rather than saying clearance, just say, I've evaluated him and he should be able to proceed with the following recommendations.
Great, thank you. And I just wanted to remind you that Dr. Lohr is available to help with any of your questions on cases. So this is in our MAVEN Project community portal. And here's a list of all of our 68 or so specialties. And he's in this perioperative medicine group here. And you can click on that and you can see Dr. Lohr, and also Dr. Bird is available as well. And I think Dr. Lohr also helps out with internal medicine, just general internal medicine questions that you have. So you can feel free to submit any consults to him as well.
Yeah,
And
it is under a separate perioperative medicine. That's the key. And I should have mentioned that. So thank you for bringing that up, Jill.
Sure, that's great. And then, as I'd mentioned too with MAVEN Project, just a reminder that if you are ever interested in one-on-one clinical mentoring or leadership coaching, we have MAVEN Project volunteers who we would be happy to pair you with, and you can develop a relationship with them over time, meeting sometimes every other week or monthly for about an hour through video. And it's a confidential, customized relationship, and they can help you to achieve and work on any of your goals that you want to with your practice. So you can go onto the portal and make a request under the mentoring tab. So I wanted to thank the Community Health Centers of Franklin County so much for requesting this talk today, and a huge thank you to everyone for attending, as well as Dr. Lohr for giving such a comprehensive talk today. And a big thank you to all of the MAVEN Project Clinic partners for all the work you do and taking such good care of your patients. They're really lucky to have you. And thank you for all the hard work that you do. So I hope everyone has a great end of their week and a wonderful weekend. And we'll see you at future MAVEN Project sessions.
Thank you.